Superior Vena Cava Syndrome, SVCS. SVCS is a mechanical emergency where nursing care, specifically positioning and avoiding compression of the limbs, is just as critical as the medical interventions themselves. It's essential to recognize subtle early signs, such as unilateral arm edema, in order to prevent a catastrophic decline. Once airway or cardiac compromise sets in, the risk of death within 24 hours is significant. Approximately 60% of cases are related to cancer, with lung cancer being the most common cause. A key warning is that facial swelling combined with blood pressure asymmetry should be considered superior vena cava syndrome until proven otherwise. Mr. Thomas Reed, 58-year-old male with untreated small cell lung cancer, central mediastinal mass. Presence with 1 week worsening facial swelling and dyspnea. Clinical presentation. Vitals: BP 148/92, right arm, 102/70, left arm, HR 122, RR 32, SpO2 88% RA. Physical exam. Facial/neck edema, periorbital swelling, jugular venous distension, JVD. Right arm edema, +3 pitting, cyanotic right hand. Dusky discoloration of chest/neck veins. Neurologic, agitated, GCS14, confused to place. Symptoms: camp button shirt, right arm numbness, orthopnea, sense of impending doom. Labs: WBC 12 000/mm superscript 3, D-dimer, 3,500 nanograms per milliliter, elevated. Imaging: stat CT chest with contrast ordered. Immediate nursing action upon arrival for a patient with suspected superior vena cava syndrome, SVCS. A. Administer lorazepam for agitation. B. Position supine for CT scan. C. Elevate head of bed 45 degrees. D. Apply ice to the edematous right arm. Answer C. This positioning uses gravity to reduce venous congestion in the head, neck, and upper extremities, decreases intracranial pressure, and helps maintain airway patency. In SVCS, where obstruction limits outflow, elevating the head of bed is a critical mechanical intervention that buys time for definitive treatment. Nursing actions, specifically positioning, are as vital as medical interventions. Prevents worsening venous congestion. Priority vital sign discrepancy requiring immediate intervention for a patient with suspected superior vena cava syndrome, SVCSA. Tachycardia, HR 122. B. Blood pressure difference greater than 20 millimeters of mercury between arms. C. Tachypnea, RR 32. D. Hypoxia, SpO2 88%. Answer B. This requires immediate intervention. A sustained inter-arm systolic BP difference greater than 15 to 20 millimeters of mercury in SVCS suggests significant compression or thrombosis involving the brachiocephalic veins or superior vena cava itself. This asymmetry reflects localized obstruction to venous outflow, which can progress to airway compromise or cerebral edema. In the mechanical emergency of SVCS, such a discrepancy is a red flag for critical narrowing and should prompt urgent decompressive measures, e.g., head of bed elevation, vascular surgery, or interventional radiology consultation. For this patient with suspected superior vena cava syndrome, SVCS, is being monitored on the unit, which finding indicates imminent airway compromise and requires immediate intervention. A. Orthopnea. B. Periorbital edema plus stridor. C. Cyanotic right hand. D. Jugular venous distension. Answer B. Periorbital edema plus stridor. Periorbital edema plus stridor are high acuity Q combination indicating imminent airway compromise. Periorbital edema reflects severe upper body venous congestion. Stridor is a high-pitched inspiratory sound caused by laryngeal or tracheal edema. Together, they represent a critical airway threat. Using clinical judgment, this is the Q pattern that demands immediate action. Prepare for intubation, notify the provider, and ensure emergency equipment is at bedside. Stridor in SVCS is a late sign of airway narrowing. Delaying intervention risks complete obstruction. A stat CT chest with contrast is ordered for this patient with suspected superior vena cava syndrome, SVCS. What is the nurse's priority preparation? A. Administer IV metoprolol for tachycardia. B. Verify creatinine clearance greater than 60 milliliters per minute. C. Hold all antihypertensives. D. Pre-medicate with diphenhydramine. Answer B. Verify creatinine clearance greater than 60 milliliters per minute. Priority is the preparation to prevent contrast-induced nephropathy. SVCS often causes renal hypoperfusion due to reduced venous return and elevated central venous pressure, which can compromise kidney function. Contrast administration in a patient with impaired renal clearance significantly increases the risk of acute kidney injury. Verifying creatinine clearance, or eGFR, greater than 60 milliliters per minute allows the nurse to ensure safe contrast administration or prompt necessary precautions, e.g., hydration, alternative imaging. This aligns with the NGN emphasis on identifying risks and taking preventive action before a procedure. For this patient with superior vena cava syndrome, SVCS, develops acute confusion with a Glasgow Coma Scale, GCS, score of 14, which is the most likely underlying cause. A. Brain metastases. B. Cerebral venous congestion. C. Opioid toxicity. D. Hypoglycemia. Answer B. Cerebral venous congestion be directly linked to the pathophysiology of SVCS. Superior vena cava obstruction impairs venous drainage from the head and neck, leading to increased intracranial pressure, cerebral edema, and altered mentation. Acute confusion in this setting is a sign of worsening mechanical compromise and can precede life-threatening airway or cardiac events. Recognizing this cue allows the nurse to prioritize interventions, e.g., head-of-bed elevation, prepare for possible stenting or radiation before deterioration progresses. For this patient with superior vena cava syndrome, SVCS, has an elevated D-dimer level. What is the primary implication for management? A. Rule out pulmonary embolism. B. Suspect thrombus within the superior vena cava. C. Indicates disseminated cancer. D. Requires heparin reversal. Answer B. Suspect thrombus in the superior vena cava. This directly aligned with the pathophysiology of SVCS. Venous stasis from SVC obstruction creates a prothrombotic environment. A thrombus often forms at the site of narrowing or around indwelling catheters. An elevated D-dimer in this setting raises suspicion for an intraluminal thrombus exacerbating the obstruction. Recognizing this cue guides management, vascular imaging, CT venography, and consideration of anticoagulation, if not contraindicated, to prevent extension of thrombus and worsening mechanical compromise. Heparin may be indicated. For this patient who is being managed for superior vena cava syndrome, SVCS, which intervention is contraindicated and should be avoided? A. Place right arm peripheral IV for fluids. B. Administer low-dose furosemide. C. Apply oxygen via non-rebreather mask. D. Obtain left arm blood pressure readings. Answer A. Place right arm peripheral IV for fluids. This is a contraindicated intervention. In SVCS, venous drainage from the upper extremities is compromised due to obstruction of the superior vena cava. Placing a peripheral IV in the affected arm, often the right side, depending on the location of obstruction, and infusing fluids adds volume into an already congested venous system, worsening edema, potentially increasing pressure on the airway, and providing no reliable delivery route for medications. The principle of avoid limb compression extends to avoiding IV access in an extremity with compromised outflow. If IV access is essential, it should be placed in a lower extremity per MD order. For this patient with superior vena cava syndrome, SVCS, reports a sensation of head fullness. What is the nurse's best initial action? A. Administer acetaminophen. B. Assess for papilledema. C. Obtain neurology consult. D. Reassure as anxiety related. When a patient reports head fullness, it may be a vague but early sign of increased intracranial pressure, ICP. The best immediate nursing action is to assess for papilledema, which is swelling of the optic disc, a classic physical sign of elevated ICP. Papilledema can be evaluated using a penlight and ophthalmoscope if the nurse is trained. While subtle cases may require an ophthalmologist or advanced imaging, initial assessment for signs like blurred optic margins, retinal changes, or vision complaints is well within RN scope if properly trained. Within scope and with proper training, RNs are expected to recognize red flag symptoms, e.g., head fullness, visual changes, altered mental status. Perform basic neuroassessments, including level of consciousness, pupillary response, visual changes, fundoscopic exam, if competent. Escalate concerns appropriately to providers. If the RN is not trained in fundoscopic exam, they can still document associated symptoms, e.g., headache, vision loss, nausea, confusion. Monitor vital signs. Initiate neuro checks. Alert the provider with a focused concern about possible increased ICP. CT imaging confirms superior vena cava, SVC, obstruction with an associated intraluminal thrombus. Which initial order does the nurse anticipate? A. IV corticosteroids. B. Therapeutic heparin infusion. C. Emergent thoracotomy. D. IV diuretics. Answer B. Therapeutic heparin infusion, this is correct, addresses the thrombus to prevent rapid deterioration. The presence of an intraluminal thrombus superimposed on mechanical obstruction significantly increases the risk of complete SVC occlusion, airway compromise, and cerebral edema. Anticoagulation, e.g., therapeutic heparin infusion, is the priority to halt thrombus propagation, restore some venous flow, and stabilize the patient before definitive tumor-directed therapy, radiation, stenting. This aligns with the principle that thrombus requires anticoagulation before or concurrently with other treatments. In NGN terms, recognizing the added risk of thrombus guides the nurse to anticipate anticoagulation as the immediate intervention. For this patient with superior vena cava syndrome, SVCS, is placed on supplemental oxygen. Despite initiation of oxygen, the SpO2 remains 90%. What is the nurse's next action? A. Increase to 100% FiO2. B. Prepare for possible intubation. C. Administer IV morphine. D. Obtain arterial blood gas, ABG. Answer B. Prepare for possible intubation. This is correct. Recognizes refractory hypoxia as a sign of impending respiratory failure. In SVCS, hypoxemia that does not respond to supplemental oxygen suggests progressive upper airway edema, impending airway collapse, or significant respiratory muscle compromise. This is a critical cue that the patient is decompensating. Preparing for intubation, gathering equipment, positioning for optimal airway management, and notifying the provider or rapid response is the priority action. Delaying until complete obstruction occurs leads to a cannot intubate, cannot ventilate crisis. This aligns with the CJMM principle of taking decisive action based on high acuity cues. A patient is awaiting tumor-directed treatment, e.g., radiation or stenting, for superior vena cava syndrome, SVCS. Which key teaching point should the nurse emphasize? A. Sleep with your head elevated. B. Restrict your fluid intake. C. Massage the edematous areas. D. Avoid all movement. Answer A. Sleep with your head elevated. This is correct. Essential self-management to reduce venous congestion. Upright posture, head of bed elevated 30 to 45 degrees, sleeping in a recliner or with multiple pillows, uses gravity to facilitate venous drainage from the head, neck, and upper extremities. This simple mechanical intervention helps reduce facial and laryngeal edema, minimizes intracranial pressure, and decreases the risk of airway compromise while awaiting definitive treatment. In the NGN framework, this teaching reflects the nurse's role in empowering the patient to manage the mechanical emergency through non-pharmacologic means. A patient is diagnosed with superior vena cava syndrome, SVCS. Which risk factor most directly increases the likelihood that the condition will become life-threatening? A. age greater than 55 years. B. Central mediastinal mass location. C. Elevated white blood cell, WBC, count. D. History of smoking. Answer B. Central mediastinal mass location. This is correct. Directly determines the potential for rapid, severe obstruction. Tumors or masses located centrally in the mediastinum, e.g., lung cancer, lymphoma, are positioned adjacent to the superior vena cava, trachea, and main bronchi. When such a mass causes SVCS, it often simultaneously compresses the airway or can quickly progress to complete SVC obstruction, leading to cerebral edema, laryngeal edema, and respiratory failure. This mechanical proximity makes the condition life-threatening with little margin for intervention. In the NGN framework, recognizing this anatomical risk factor allows the nurse to anticipate rapid deterioration and prioritize aggressive monitoring and preparation for airway support. A patient with superior vena cava syndrome, SVCS, develops sudden bradycardia with a heart rate of 42 beats per minute. What is the most likely underlying cause? A. Vagal stimulation. B. Reduced cardiac preload. C. Sinoatrial node compression. D. Opioid overdose. Answer B. Reduced cardiac preload. This is correct. Directly linked to the pathophysiology of severe SVC obstruction. Severe SVC obstruction impairs venous return from the upper body and, when critical, can significantly reduce overall preload to the right ventricle. This reduction in preload decreases cardiac output and can trigger a compensatory bradycardia, or more ominously, can be a pre-arrest sign as the heart becomes underfilled and perfusion fails. In the NGN framework, recognizing sudden bradycardia in SVCS as a cue for impending cardiovascular collapse guides the nurse to immediately act to improve venous return and prepare for resuscitation. A patient with superior vena cava syndrome, SVCS, develops significant edema in the right arm. Which nursing intervention is most appropriate? A. Apply warm compresses. B. Elevate the arm and assess pulses. C. Administer IV albumin. D. Restrict protein intake. Answer B. Elevate the arm and assess pulses. This is correct. Addresses both venous congestion and perfusion monitoring. Elevating the affected arm uses gravity to facilitate venous drainage, reducing edema and discomfort. Assessing pulses, brachial, radial, evaluates arterial perfusion, which is critical because severe edema can occasionally compromise arterial flow or indicate thrombotic progression. This intervention aligns with the principle that nursing actions, specifically positioning and avoiding compression, are as critical as medical interventions in the mechanical emergency of SVCS. A patient with a history of superior vena cava syndrome, SVCS, treated with stenting and/or radiation is being discharged. Which priority teaching point should the nurse emphasize to help the patient recognize early signs of recurrence? A. Report facial swelling or arm heaviness. B. Monitor daily weights. C. Limit sodium intake. D. Avoid air travel. Answer A. Report facial swelling or arm heaviness. This is correct. Addresses the subtle, early signs of SVCS recurrence. Facial swelling, especially upon waking, and arm heaviness or edema are among the earliest indicators that venous outflow is again becoming compromised. These symptoms can precede more dangerous signs such as dyspnea, stridor, or neurological changes. Teaching the patient to recognize and report these subtle cues allows for early intervention before the condition progresses to a mechanical emergency. This aligns with the NGN emphasis on patient education that empowers recognition of key cues and timely action. SVC crisis, mnemonic for SVCS emergency protocol. SVC crisis. Semi-Fowler's position, 45 degrees. Vital sign discrepancies, BP bilateral arms. Contrast CT prep, renal protection. Cardiac/respiratory support, O2, intubation ready. Rule out thrombus, heparin if D-dimer. Immediate anticoagulation if thrombus present. Skin/neuro checks, edema, ICP signs. Inform team about limb access restrictions. Symptom relief, opioids for dyspnea, reassurance.